Thank you for having me here also this year. Thank you. So my presentation is about understanding ventricular fibrillation mechanism from ECG. We can go back in the first definition of ventricular fibrillation, and actually I had to go very far in 1923 when the ventricular fibrillation was defined as an abrupt replacement of the effective systole by a continuous turmoil of uncoordinated activity in the muscular bundle, characterized with an excessively rapid small contraction, each of short duration. But in 1981, we first have characterization of ventricular fibrillation as an organized activity, organized arrhythmia. And in 1998, we have these beautiful publications that characterize this year as the golden year for ventricular fibrillation, and definitely was accepted in the scientific world that the ventricular fibrillation is a phenomenon that is coordinated. Actually, it has a spatiotemporal evolution. So I reported here the cornerstone of the 1998 published by the group of Jose Jalife, and they stated that yes, ventricular fibrillation had been defined as turbulent cardiac electrical activity, but recently, so in 1998, the application of nonlinear dynamic theory to the study of wave propagation in the heart enabled investigators to think as ventricular fibrillation as a problem of self-organization of nonlinear electrical waves. And this led to demonstration of a high degree of both spatial and temporal organization during the ventricular fibrillation. But what is this nonlinear electrical activity? So the definition of nonlinear dynamics in the branch of physics is a branch of physics that studies system governed by equation more complex than the linear equation. So a nonlinear system, such the weather or the neurons, often appear chaotic, unpredictable, or counterintuitive, but their behavior is not random. And for me, this is the best definition for ventricular fibrillation, that in fact appear chaotic, is unpredictable, is counterintuitive, but the behavior is not random. A simple nonlinear system that is similar to ventricular fibrillation is a sinusoid. Of course, it's not exactly the same, but you can see that the behavior is quite similar. And this is important because a sinusoid can be represented as a phase. So the concept of phase is quite difficult to explain in few minutes, but the only things we need to know is that phase is the position of a point composing a waveform on a cycle. So as you can see here, for example, in this picture, the point A in this waveform, it corresponds to this vector on this phase. And when the sinusoid, the curve, goes in this position, the position B, the point B can be represented in the phase in this position. And again, the highest point is represented in the phase in this position. And when the sinusoid goes in the descending part, we are in this part of the phase. And again, when we have this descending part, we are in this part of the phase. And as you can see, when we go back in the isoelectric line, we can call it like this. So we have again the point A, the phase is back to the initial point. So this is a method to represent a wavelet, a waveform, and the phase is a dimensionless quantity, is measured in degrees or radiant. One complete cycle spans 360 degrees, and the phase specifies the location of each point of the waveform in a cycle. This is what we need to know to go ahead and explain the phase mapping. So if the ventricular fibrillation was a perfect sinusoid, the phase mapping that we will have will be like this, a perfect cycle. And if the ventricular fibrillation was a completely random phenomenon, the phase mapping we will have, it will be something like this, completely chaotic. But the ventricular fibrillation is not chaotic. We said appears chaotic, is unpredictable, is counterintuitive, but its behavior is not random. And in fact, the phase mapping of ventricular fibrillation is this, and it rotates around a central point that is called attractor or phase singularity. So we can use the phase mapping to localize the rotors during ventricular fibrillation. But what is a rotor? So in literature, there are so many definitions about rotor and rotational activity. One of the simplest and more accepted is that rotational activity is a phase consisting in at least one rotation. And the rotors are the fine region of rotational activity that controls surrounding activation. So a rotor is not only something that rotates around an attractor, but is also something that can spread the activation to the tissue underneath. And here we can see a publication of 2021. And here, with this nice picture of a rotor, a simple drawing of a rotor, we can clearly see that it's quite similar to the phase we explained before. We have these three mechanisms of rotor onset. It can start from a focal source that can produce a stable rotor, or they can be generated from a passive waveform that can produce a stable rotor, or again, the conduction block can produce a stable rotor without a pivot point, a central pivot point. Keep this in mind because later I will show you some example of ventricular fibrillation that proceed in this way. But it's also important to remember that phase mapping can present a huge bias for us because a wannabe reentry, so an incomplete reentry, can sometimes be represented in a phase mapping as a rotor, but is not. So how can we be sure that what phase mapping is showing us is a rotor? We have always to check the EGM or the ECG, and we have to be sure that we have an activation sequence. So we have to be sure that each point that is around the rotor, so each point of the phase mapping, is going in this activation sequence. So the activation is rotating around the central part. How can we perform a phase mapping? There are different methods. The important thing is that we have a whole complete view of the heart, because of course we need to have a good and nice representation of whole tissue. There are studies in literature done with endocardial multi-electrode mapping. We can use the body surface mapping. We can use the optical mapping. Today I will show you an example with the body surface mapping. So in the left panel we can see the induction of a ventricular fibrillation, and here we can see it was inducted by a burst. So we have the pacing and the first ventricular paced, again a pacing spike, again a QRS paced, and then you can see that from here ventricular fibrillation established. In fact, the next pacing spike are inside the QRS. And so here you have this situation, the beginning of ventricular fibrillation. So the first two beats are the beats that are paced, and then we have the ventricular fibrillation onset. So what we can see, so we have this focal activity, that is this activation that is starting from, as you can see, the breakthrough is in the anterior right ventricle, because we were pacing from the right ventricle, so the breakthrough is in the site of the pacing. And we can see that the activation is proceeding in focal activation. Here we have a period of disorganization of the activity, and in fact you can see that the phase map is broken here. And then the ventricular fibrillation has started. But in this region, so in the anterior region, again, we see something that is proceeding in with a focal activation. So we have the propagation that it seems to be focal. But what happens if we rotate our map? If we rotate our map, we can see that in the posterior view, we have the first two pacing beats in which we have the wavefront from the anterior wall. And then when the ventricular fibrillation starts, we can see that it starts a rotational activity. And so what we see in the anterior wall is just the passive activation of this rotational activity, this rotor, that is leading the wall ventricular fibrillation. What is the mechanism of this rotor? Do you remember these are the three cases I showed you before? Probably this is the second case. So because of the first paced beat from the anterior wall, we have a repetitive wannabe re-entry. So something starts to establish, you wanted to establish in the posterior wall. And in fact, we generated with this passive wavefront from the anterior wall for the pacing beats, we produced a stable rotor. Then, in this patient, the rotor moved from the posterior aspect to anterior aspect, and then it moved towards the left ventricle. So when the rotor was based in this anterior wall, what was the mechanism? Probably was the first one. So because we were pacing, we had this focal activity from the anterior wall, the rotor shifted in the anterior wall because we had this focal source that produced a stable rotor. You have to think about ventricular fibrillation as something that continuously produces rotor, and the rotors continuously migrate in the ventricle. So the same ventricular fibrillation can have several rotors that are leading the arrhythmia. And at the end, this ventricular fibrillation start to rotate in the lateral aspect of the left ventricle, and it stays there long time, and was nice to see that it was very close to the PVC that the patient had in the baseline. So probably in that region that was something that was a good point for the ventricular fibrillation to establish there. What is the mechanism of this last rotor? We don't know. Maybe it was the second mechanism, so because of the passive wavefront from the anterior wall, or maybe it was a conduction block that producing this stable rotor. We don't know. Of course, a voltage map can clarify the mechanism of rotorgenesis, because if we see that we have a block line in that part, we can conclude that maybe it's the third mechanism. So the take-home message is the ventricular fibrillation is not a completely random and chaotic event. Instead, it exhibits spatial and temporal organization. This characteristic can be quantified and analyzed mathematically using phase mapping in the context of studying rotors. Integrating various techniques can provide valuable insight, bearing in mind that each methodology has its limitation. Thank you.